Hello everyone. Today my topic is about the pathology, and we will talk in two topics, some brief and important informations. We will talk about DIC, disseminated intravascular coagulation, and also we will talk about the TTB, which is thrombotic thrombocytopenic purpura. So first of all, if you look at this diagram, we want to talk about the DIC. So first of all, the DIC is a condition in which you have multiple area in which there is formation of thrombus, and in a way that there are many uncontrolled thrombus, and so in other area they will be, I'm gonna draw it down. So in one area here you will find the clotting and the formation of the thrombus, and there will be too much consumption of platelets and the coagulation factors and everything. So in other area you will find maybe you have an injury and you will not be able to make a thrombus here, a normal thrombus, because they are consumed already. So this is the basis behind the IC. So what is the thing that will trigger the condition? Everything can trigger it. So for example, if you have sepsis, okay, in sepsis there will be pro-inflammatory cytokines that are released. This will lead to damage to the endothelium and activation, and because of this thing there will be recruitment of the platelets and the things that happen in the normal homeostasis, it will occur here. Okay, so there will be formation of the clot, injury, and then they are zooming as injury, but there is no injury. You cannot see any injury. Anyway, so you will see this platelet will stick in one area, and then the fibrin mesh will be around it, and it will be in multiple area. Okay, so it's uncontrolled multiple area. So there is other condition. For example, if you have malignancy, there will be also pro-inflammatory cytokines, and they will lead to activation of the endothelial cell, and this is the pathophysiology behind it. Now, what is the lab diagnosis? I mean, the test you can see. First of all, the platelet count, of course, it will be decreased. Why? Because we said that there will be multiple area, you will form a thrombus, and there will be consumption of the platelets plus the coagulation factors, both intrinsic and extrinsic pathway. So the prothrombin time, which is the time that the test with which determine the function of the extrinsic pathway is increased. Also, the activated partial thromboplastin time, because the coagulation factors that is associated with the intrinsic pathway will be decreased. So the time, of course, will be high, more than 40 seconds, more than 12 seconds in the PT. And the fibrin degradation product is high. Why? Because the fibrinogen will be, of course, activated to fibrin because the coagulation factors are activated, and this fibrin, by the action of a plasmin, okay, will be degraded, and so the fibrin degradation product will be high. Okay, and this condition will also interfere with the normal homeostasis, and there will be difficulty in maintaining the homeostasis because it can interfere with the process of formation of the activation of the factors and everything. So this will contribute to the bleeding in other area, so it will be increased. Okay, fibrinogen might be normal or decreased. Fibrinogen, because fibrinogen will be converted to fibrin, that's why it can be decreased. And you will have antithrombin 3, which is the normal factor and inhibits some coagulation factor, it will be decreased. Now, what are the signs and symptoms? So basically, the patient will present with bleeding, such as severe bleeding, which occur in the GI, and you can monitor it, like you can understand if there is GI bleeding by doing, like, for example, a catheter. You will find the hematuria, and also the melena. Okay, the stool sample, they will be very black because of the bleeding. Petechia and ecchymosis. Why? Because there will be, you can see this picture here, because they will be bleeding under the skin. Okay, there is low platelets, so the cause of this is low platelets. Okay, and they will be petechiae. And intravenous line on catheter lead. Yeah, if the doctor administer an IV for antibiotic, for example, there will be severe bleeding. Okay, and also the catheter, as I mentioned here. Of course, because this DIC will lead to ischemia, right? It's like some area here, if you have, for example, the kidney, you have the brain, you have any area, there will be ischemia. Okay, why? So first of all, I forgot to mention about the clinical the lab finding. There will be something called as microangiopathic hemolytic anemia. So there will be thrombus, right? So once the RBC passing here, they will shed. So they will form schistocytes. Okay, a helmet cell, and we will see it later in the under the microscope. So this will contribute to the ischemia to other area. Now, moving to the second topic. The second topic, we will talk about the thrombotic thrombocytopenic purpura. Now, this condition basically, usually they are genetic or acquired. Now, the acquired will be autoantibody against this enzyme. So, what's this enzyme? So, first of all, the von Willebrand factor, it's composed of 3 main sites. Okay, one is for the binding of the collagen, and one is the binding for the platelets, and the other is the binding to the enzyme. Now, this enzyme, which is TS13, will help to cleave this von Willebrand factor, so they will prevent the thrombosis. Now, and of course, it will make its function, which is the binding to the platelets and facilitates the adhesion to the collagen. Now, if this enzyme is not here, there will be ultra like ultra multimer von Willebrand factor, and this is not normal because we said the normal is this one, and this will lead to recruitment to the platelet. Too much platelet will be sticking in this side, and too much fibrin will be here, and thus will lead to what? Will lead to thrombotic thrombocytopenic purpura, thrombosis and everything. Okay. Now, because this condition also leads to thrombosis, so you will find these microangiopathic hemolytic anemia and schistocytes. The sinus symptoms, there will be triad of fever and a neurological central nervous system neurological symptoms, and you might see kidney symptoms, but it's not very frequent. Okay. And of course, there will be anemia, okay, because of the schistocytes. And because now, why we have CNS manifestation? It is because of decreased blood supply to the CNS, and this will lead to this sinus symptoms. You can see kidney failure, but it is rare. Okay, you will see it more in HUS, which is another topic, and we will talk about it in separated video. And so this is all about the sinus symptoms. You can see this fragmentation. Okay, and this is the schistocyte that I told you about. Okay, see, this is the normal cell, and this is the schistocyte. Why? Because we have a thrombus and the blood passing here, so they will be shedded. Okay, this is just a comparison between the TTP and DIC. You can see the platelets, both of them are decreased, okay, and the blood smear is the same. But the PTT, now remember that DIC will consume the coagulated factor, but TTB, because it's sticking in the von Willebrand factor, okay, and so they will not consume any coagulation factor because there is no activation also, okay. So just keep this in your mind, because this is how you can from the history, if they give you this picture in the exam, from the history you can understand whether it is TTB or DIC. Fibrinogen also help you, and D-dimer, because whenever you have too much degradation of fibrinogen, you will have D-dimer. Sorry, not fibrinogen. Yeah, I make this a mistake. Fibrinogen, when it is degraded, they will not give you D-dimer. But if they are the fibrin itself, which is converted from fibrinogen, by a the coagulation cascade, they will give you the D dimer. And yeah, this is all about it, and I hope it was clear. If you have any question, I'm ready to answer.